Well, welcome back, everybody. I hope you enjoyed that 3 hours of collaborator showcase. Thought the lightning talks were really great, and it was really good to see so much engagement in both the poster rooms and the software demo room, and seeing everybody collaborating, as well as seeing people networking and talking throughout our space. So this closing talk is going to be about collaborating on evidence at scale, and I'm going to hope to tie together some of the themes of what you all heard about today and provide another call to action for what we can be doing together. And that's going to include a lot of fun later this evening after my closing talk, but you just got to bear with me for a few more minutes. So first, I want to thank again our colleagues at the FDA for their generous support for making the Odyssey Symposium happen through the FDA Scientific Conference Grant. Thank you, FDA. I also want to thank our sponsors, Johnson & Johnson, Boehringer Ingelheim, EPAM Odysseus, and Nemesis Health for their contributions to support our community. I want to thank again our Odyssey Scientific Review Committee. So if you did enjoy the Collaborator Showcase, that was 100% because of them and all their hard work to do diligent peer review of all the great science that's in our community. So thank you, Scientific Review Committee. I want to congratulate again all of the 2024 Titan Award nominees. I actually think, one of the privileges I get of working with George and doing things on behalf of the Coordinating Center is that we get to be the bearer of good news. And it's always fun to actually send out the email to celebrate the nominees. And it's funny because I get responses from some of y'all like, I can't believe you nominated me. And my response always is like, I didn't nominate you. Somebody else in the community recognized the great stuff that you were doing and recognized your contributions. So congratulations to all of the nominees. And another round of applause for all of our winners of this year's 2024 Titan Awards. And I want one last big round of applause. Thank you for all the people who made today happen. Elise does more work than you guys could possibly imagine. It was wonderful that so many of you nominated her and recognized her contributions for this. So I want to specifically call out Elise. Thank you for everything you do for our community. I also want to thank all the other volunteers who, when voluntold to participate, were first told, hey, will you come help with putting on a scientific conference? And then we're told, oh, by the way, Patrick's got a crazy idea for a game night that's going to run all night, and you just have to bear with him. So thanks in advance to our volunteers who will be helping for a few hours later, who only kind of know what they're doing. Yes, thank you. I also want to make a thank you to an anonymous contributor in our community. As many of you know, Odyssey celebrated its 10-year anniversary, and we had a collaborator that, in recognition of Odyssey's 10th year anniversary, had 100 trees planted to help restore a threatened forest from American forests. And it says, happy anniversary to the 3,000 Odyssey collaborators. So I want to thank this contributor. And I want to specifically call out to Jenna that this will be the only time that I'm celebrating a random forest. Sorry, my daughter's not here, but I still have to do at least one dad joke. All right. Okay. So, many of you have come to the Odyssey Symposium and saw me do some pretty crazy stuff up here. And usually I've been trying to do it to motivate you all about what our purpose is. In 2022, 2 years ago, we did a very elaborate metaphor about collaboration at scale, where I subjected you all to the tortures of building a Lego statue, which was good fun, and you guys were actually quite successful in taking individual projects, putting them together, and building a solution. And I was hoping that the metaphor for building a better future would be something that you'd be able to carry forward and propel you to motivate to think about how to translate that metaphor to actually doing science. In 2023, last year, I thought, let me build an even more elaborate metaphor. And I built an escape room for 450 people. The motivation of that escape room was that you all were supposed to collaborate together at scale to complete a series of puzzles so that you collectively could win. For those of you who were here, do you remember what happened? You failed. So, still some of you came back. Now, this may be maybe because I made a very bad escape room. I was told that by at least a couple people, and I'll own that for sure. But I also think it may be because there's still work and opportunity for us to figure out how to collaborate at scale. We probably saw at least a few suboptimal behaviors that happened when we tried to get 450 people to work together. If you watched the recording from the closing last year, you'll know what I'm talking about. Right? But what I realized is actually the problem here is that for the last 2 years I've got it up here and I've tried to give you these grandiose metaphors for how we need to generate evidence at scale. And so this year I'm not going to do something crazy and zany to get you to think about some sort of weird cryptic metaphor for evidence at scale. Instead we're going to do crazy and zany things after this during game night. I got one woo and one laughter. That was it on that. Okay? So instead of having an elaborate zany metaphor, I just thought, since I've got you captive in a room with 450 people, why don't we just go ahead and generate evidence at scale? So true story, totally real. I had this idea for what I was going to do for this collaborator showcase, and I thought, you know what we're going to do is we're going to set a Guinness World Record for the most evidence generated at scale in an hour. And I contacted Guinness World Records, and I was like, listen, I want to do this. I want you guys to come out, and I want you to anoint us as the world record holder. And the first response I got back was, who the hell are you? And then a second, I was like, no, I'm real. Like, I'm really going to actually do this. And they responded back by saying, we don't think that could be done, so we're not going to spend our time on it. So if for no other reason, I want to do this with y'all, because we're going to set a world record unofficially and do something that even the Guinness Book of World Records thinks is not possible. All right. So, you heard today during our plenary session about Legend type 2 diabetes. You saw the initial paper that was published pre-specifying a protocol about Legend type 2 diabetes, and you saw clinical insights from this study comparing classes of treatments. And you also heard from our data network about the value proposition that came from participating in the study. Now, you also saw we had that very fun Q&A where all of the Odyssey Legend co-authors were up here on the stage, and we had a nice Q&A. I'm tremendously proud of what our community has done with the Legend studies. I'm tremendously proud of the leadership of Mark Suchard. I'm going to clap for him. Because doing evidence at scale is hard, and pulling people together is hard, and doing reliable evidence generation en masse across lots of organizations, lots of data partners, and lots of individuals is hard. And what we've learned probably more than anything else is disseminating evidence is particularly hard. As a case in point, this morning, after now we're basically like 3.5 years into Legend type 2 diabetes, you got to see 5 short presentations from 5 individuals about 5 insights from the Legend type 2 diabetes study. But I'll remind you that while you saw information about 4 drug classes, each of those drug classes contain a wide array of active ingredients. There are 5 DPT-4s, there are 6 GLP-1s, there's 4 SGLT2s, and there's 7 sulfonylureas. That's 22 distinct drug ingredients. I'll also remind you, for those of you who aren't thinking about it, that patients don't take classes of drugs, at least not usually. They take individual ingredients. And so patients are making individual choices about individual ingredients. And this morning, you actually didn't hear any insights about a particular ingredient at all. I'll also remind you that what you saw was 6 individual short stories about 6 insights, but in fact the Legend protocol highlighted 32 different outcomes. So I want you all to appreciate and recognize the scale of what Legend type 2 diabetes is, and also recognize the distance between where we are right now as a community and where we need to be in terms of having the value and impact of Legend type 2 diabetes take shape. So to represent this in just a different visualization to help you think about this, I want you to think about the following grid. This is a grid where those 22 ingredients are listed in the rows, and those 22 same ingredients are listed in the columns. So you could think about it for any given outcome, like myocardial infarction. You've got 22 target drugs and you've got 22 comparator drugs. Each of these cells representing a target, comparator, outcome represents a clinical question that someone could want the answer to. Now, specifically here, given that I've selected a given outcome, we're talking about 462 target comparator combinations in all. These are real questions that someone could ask. You or a loved one, somebody who's finished up their metformin and needs to have an appropriate second-line therapy, could legitimately ask the question, should I take any of these target drugs or any of these comparator drugs if I'm particularly worried about cardiovascular risk of myocardial infarction? That's a legitimate question that deserves a legitimate answer. But the Legend type 2 diabetes study doesn't just provide this one grid of all the targets and all of the comparators for a given outcome. It actually contains all of these outcomes. So we actually have this 3-dimensional grid of lots of targets, lots of comparators, lots of outcomes. All of this evidence was generated by this one study that we've conducted together. And across the 32 outcomes, that means there's 14,784 target comparator outcome combinations represented in this space that we can consider to be important. Now, what I want to reinforce for all of you is that every single one of those target comparator outcome combinations is a valid clinical question, and I'll assert that patients deserve reliable evidence to answer that valid clinical question. And yet this morning, we just celebrated that we got 6 showcase presentations of 6 individual hypotheses about the drug classes, and still haven't figured out a way yet to disseminate all of this evidence across all of the indications and all the targets and all the comparators and all the outcomes. So we still have a long way to go. Now, the challenge with the collaboration at scale is that Mark has done truly an inspiring job trying to lead our community, bring together early stage researchers and senior researchers, researchers from industry and academia and government, all working together towards doing the best we can to push forward the Legend results. But I think that there's 2 dimensions about evidence at scale that we need to think about. Martijn has innovated on behalf of our community to prove that we can generate evidence at scale. We can fill this grid and have databases with all of these numbers. The nut we haven't cracked yet is how do we disseminate those numbers out into the broader ecosystem. And I'll assert that as great as Mark has done in leading our Legend type 2 diabetes effort, and as many wonderful collaborators you had on the stage, that does not scale to 14,784 questions. If we're going to start disseminating at scale, we can't just generate at scale, but we need to figure out new ways for us to collaborate at scale to get this information, reliable information, out into the hands of those that need it. Now, Martijn, 2 years ago at the Odyssey Symposium during the plenary session when we presented objective diagnostics, laid out a future vision. And I'm going to take a second to go through this slide because I think it's actually still probably one of the more profound things that we've actually presented that I'm quite proud of. If we think about the traditional current way that observational research is done, so any old researcher can come up with a custom bespoke research question. They then go through the journey of trying to generate evidence. They then do whatever they feel like is necessary to interpret study reliability. They then interpret the results, and then they aim to use that evidence primarily through writing up whatever it is they did in a publication and submitting that. Hopefully soon to be rejected by Jack once you all are reviewers. Now, in the Legend hypertension study, we asserted that we had made progress towards this problem because what we actually did was we standardized the research questions, And we standardized the evidence generation process. And by doing that, that meant we were producing consistent artifacts every single time. But as we recognized at that time, we still hadn't figured out exactly how to interpret study reliability or to actually interpret the study results. And so while I'm tremendously proud of the work that we did in legend hypertension and the dozen or so papers that we published out of that, that dissemination process was still painful. Chan's nodding very vigorously as the lead author of several of those papers. So what we recommended 2 years ago was this notion of objective diagnostics. And the breakthrough that we thought we had that we offered up to y'all was that not only can we standardize the questions and standardize the evidence generation process, but for the first time we had standardized study reliability. By having objective diagnostics, we could actually pre-specify rules that would tell us whether or not we trusted the evidence. And at the time we said, okay, we've got all the way there. Now all we just need to do is just let people interpret the results however they want. The last thing that Martijn said in that presentation, though, was the future, where we would like to go, is if we can standardize the questions and we can standardize the evidence generation and we can standardize study reliability, can't we figure out a way to standardize the interpretation of results? And that was a vision and a challenge to the community, and one of the reasons why one of our priorities for this year for our community was to think about progress we can make towards evidence dissemination. Now, before anybody gets their hopes up and thinks that I'm going to now magically reveal an automated solution to do this, we have it, but we're not showing it to you. Instead, what we realize is that there's a different dimension about standardizing in the interpretation of study results that does not involve replacing the human with the machine, but actually involves figuring out how to get a community of humans thinking in a standardized way about the interpretation of results so that we can all be consistent in the manner in which we use evidence that we can generate. So what I'm going to lay out for you is a rubric for interpreting studies. And we actually spent quite a bit of time trying to come up with this general rubric. I'm sure I'm going to offend or at least create something that's disagreeable to several of you, because nothing that I'm going to show you is in any textbook or even the Book of Odyssey. This is something that I'm offering up as a proposal of a way to think about interpreting studies, given that we've generated them. The first dimension of this is that we should think about the quality of the study itself. And there are really three primary attributes that I would assert are part of a quality study. One needs to have a quality study design. Ideally, what would make for a quality study design is some sort of specification of multiple analytic designs to evaluate robustness. Say, for example, using multiple methods like a comparative cohort method and a self-controlled case series method. Potentially multiple analyses within a design. For example, running sensitivity analyses to evaluate your propensity score or thinking about different times at risk. As well as specification of objective diagnostics that test the statistical assumptions, quantify residual error, and establish unblinding rules. Second dimension of what I would assert is a quality study is something that is fully transparent. You heard, George's continued edict of openness and verification. Openness is about having a pre-specified protocol that's publicly available for everybody to read, but also coupling that with publicly accessible and analytic source code so that you know exactly how the analysis was performed, as well as full provenance of the result set. Not just the cherry-picked numbers you choose to write up in your paper that will be accepted in JAX shortly, but actually all of the results that you need. The third dimension of quality of study is the diversity of databases. And this is why I was really thrilled to see our panel that Claire led and to hear from Scott and Talita and Atif about the value proposition of data partners. Because the only way this is actually going to work for a quality study is if we have diversity in populations, diversity in geographies, diversity in data capture processes. Now, I'm going to assert that there is no magic to quality, that it's either good or bad, yes or no. But I believe that when we talk about these words of quality, we need to actually have dimensions that we can define to say what happened in the study design, what happened as related to transparency, and what happened as related to the data network that we can actually quantify and describe as it relates to the dimension of study quality. But once you have study quality, you're going to execute an analysis and generate results. And so the question is, how do you actually interpret the results you generated? And here again, I'm going to assert that there's a trinity here of elements that we want to focus on. The first is the strength of the evidence. How confident are we that we believe the thing we're about to look at? And I'm going to assert that this is a continuum. There is the possibility that a high quality study, meeting all of the criteria before, still can produce no evidence. In fact, it's actually quite easy to imagine how that could happen. All you'd have to do is fail your diagnostics. This is actually informative information to say that you could not produce any evidence, although it's probably the disappointing state that most researchers don't get into, and of course most researchers are not pre-specifying diagnostics and blinding themselves. Now, an example of a weak strength of evidence, not no evidence, but like not so good evidence, would be the situation of you got one database that passed diagnostics, and maybe you got a whole bunch of databases that failed diagnostics. The reason why that would be weak is because I think we've learned from the totality of observational research out there that one analysis on one database is highly unreliable, and in particular in the face of knowing that other databases can't produce reliable evidence should make you even more skeptical about that one particular database artifact. Now, on the other end of the continuum, you could imagine what really would be strong evidence. And I would assert that if you had lots of diverse databases, all passing diagnostics, very few or none failing diagnostics, conducting a meta-analysis to synthesize the evidence all together, and that passing diagnostics, it's really hard to think about how that can possibly not be strong evidence. And so as we had the panel with Harlan and Yuen and Chan and talking about the partnership with Jack and talking about meta-research, what I'm really excited about is the contribution we can make as a community is how do we actually define strength of evidence, formalize it, and represent that in the way that we conduct studies. But this is just about whether you trust the answer or not. It still doesn't tell you what the answer actually is. There's two more dimensions to that. There's the certainty of the estimate, and there's the size of the effect. So my assertion to you all, my proposal as a way that we could frame things up and think about it moving forward, is that we want to be able to generate reliable evidence by having high quality studies, strong evidence, maximize our certainty in the estimates, and then look at the effect estimate we produce as the basis of being the answer that we can trust. Now, this is a proposal. I need to test out my hypothesis that this can actually work. So what I need you to do is collaborate on evidence at scale. You have another folder on your table right now. I'm going to ask you to open up your folder and pass out the individual pieces of paper. You're also going to need a black marker, which should be a stack of them on your table. We're gonna play a game here, but you actually need to be engaged and participate fully. So you need to be paying attention to the rules, following along as we go through this process. Okay? So everybody in their hands right now should have a piece of paper. At the top it should say Legend Type 2 Diabetes Evidence Dissemination Summary. You should have a black marker in your hands. Okay? That's what you're going to need to do this exercise. I see a bunch of people standing in the back not participating. Unacceptable. Asia, get your butt in a seat. Alexander, find a seat. We need everybody to contribute to do evidence at scale. Okay, so you've got your form. So now I'm going to walk through an orientation, and I want to explain briefly why I'm doing this. Generating evidence and disseminating evidence is not some sort of abstract concept. And it's also not something that you all need to be scared and intimidated by. There's nothing special or magic about those that participated in Legend Type 2 Diabetes versus those that didn't, other than people had the courage to want to be part of an open science community and collaborate. That should be all of you. And so, as proof of that, that is all of you right now. What you are holding is real results from the Legend Type 2 Diabetes study. Every one of you in this room is holding a unique hypothesis. At the top of your page, you can see what is your target drug, your comparator drug, and your outcome. That is your study that you are holding on to, that you are going to learn whether or not we have reliable evidence for that question. You have nobody to lean on because everybody in this room has a different case. And remember, I told you we got over 14,000 of these. There's only 500 of you in this room, so I had plenty to sample from. Okay? So, and also big shout out and thank you for Martine for making these quite pretty, because I had this idea and I created something and Martine scoffed at me and said, no, I'm going to make something way better, which he definitely did. So thank you, Martine, for that. Okay, so we're ready to go through our Legend Type 2 Diabetes Evidence Dissemination Summary. First thing I want to draw your attention to is the middle section. This is your database diagnostics. It's the blue box that says, how reliable are your effect estimates? These are your objective diagnostics. Objective diagnostics are not just some sort of random abstract idea. They are quantified numbers, and we're going to explain exactly what they are, exactly what the thresholds are, and exactly how you can determine whether or not you pass diagnostics or not. Okay? So here we go. The first column in that table, at the very bottom, you'll see it says the word preference score. This is the diagnostic of empirical equipoise. Specifically, what the diagnostic is asking is what proportion of the target population is close to treatment indifference. The score that you see above that little graph, it says equipoise and has an equal sign. That is your value of your diagnostic. You pass this diagnostic if the equipoise score is greater than 0.25. You fail this diagnostic if the equipoise is less than 0.25. Your action right now is to take your black marker, and if your equipoise is less than 0.25, I need you to draw a black line through that database and blind it. So each of you should be seeing about 10 different databases. 1, 2, 3, 4, 5, 6, 9 databases. You could be blinding none of them. You could be blinding all of them on the basis of this first number. Okay. So what I'm specifically, and I'm going to show you. I'll skip ahead. So what I want to specifically see you do. You're going to draw a black line all the way through the line if you failed the diagnostic, but we're going to go through the columns one by one.
What if it's an empty row?
If it's an empty row, you don't have to worry about it. Okay, so now that you've marked your empirical equipoise, what I want you to do is stand up if you eliminated one or more databases. Okay, I want you to, everybody look around and get a sense of this. And I'm not going to write down specific numbers, but I would say roughly we're looking at like, what do you say, maybe like 35% of people are standing up right now. Think about what that means. You guys can sit down now. Think about what that just means. There's a 30% chance that if somebody performed an analysis on a given database, the database that failed diagnostics, that if they didn't look at this diagnostic, they might produce something that's unreliable. 35% is a lot. 35% of you have at least one piece of evidence that would need to be blinded. Okay? How many of you, raise your hand if all of your databases failed the diagnostic of equipoise? We got one hand. Yeah, I was just picking on you. Okay, so you, singleton in the room, you had a question, a very valid question that patients deserve reliable evidence for, and yet your answer to this question is going to be, I cannot produce reliable evidence. And that's okay, because for whatever reason, that target comparator outcome question you're asking, we've learned that just for one diagnostic alone, we don't have the ability, given these methods and these databases, to constitute reliable evidence. And that's okay. Thankfully, it's only one so far. Our second diagnostic, the second column over, the one at the very bottom says ASDM. This is the diagnostic of covariate balance. The ASDM is the absolute standardized difference of means. The idea of this diagnostic is to ask the question, are all observed baseline characteristics sufficiently similar between the target and the comparator cohorts? Now, I say all observed characteristics, not just the ones I cherry-picked to choose to put in a model, but everything that's observable in my data. I want to prove that they're sufficiently similar. And we pass this threshold if the maximum ASDM is less than 0.15. We fail this diagnostic if the value is greater than 0.15. Now, do not get hung up on why I picked these particular thresholds. The most important point is that I've defined a threshold that I've pre-specified that you're all going to look at. So right now, you should be using your black marker to scratch out any database for which the maximum ASDM is greater than 0.15. Now, on the picture, what you're actually seeing is you're seeing the yellow box plot is showing you what was the standardized mean difference prior to adjustment. So like in this passing example, you can see that the maximum there was almost 0.5. But what we're actually evaluating with this threshold is where the green bar is, trying to make sure that the maximum that's on that little confidence interval is less than 0.15. Stand up if you failed at least one database on covariate balance. I want you to look around. I'd say it's somewhere like 80% of the room is standing right now. That means 80% of studies, when running an analysis on a given database, failed diagnostics about whether or not we can actually adequately balance our baseline characteristics. Raise your hand if you have now failed diagnostics on all of your databases. Everybody's still alive with at least one database. Okay, let's keep going. Statistical power. This is your third column. The number, the value, the description at the bottom is MDRR. That stands for minimum detectable relative risk. The idea of the diagnostic is to ask the question, how much data is sufficient to provide useful information? Our pre-specified threshold is to pass if the MDRR is less than 4, and to fail if the MDRR is greater than 4. What you're seeing on the plot is a little bar plot. You're hoping that your bar is less than the value 4. You need you to use your black marker and cross out any databases that have an MDRR greater than 4. You can keep the databases that passed. I need you to stand up if you crossed out at least one database on minimum detectable relative risk. Okay, I'd say maybe 25% of the room had at least one database that failed because you didn't have adequate power in the given database. So I don't actually remember all the numbers, but I'm saying it's something like 40% for the first one and like 85% for the second one, and now another 20% failing here. Okay? Okay, our fourth diagnostic is what's listed here actually on the plot. It's going to show the word hazard ratio, and over the plot it shows the term ease. This is the expected absolute systematic error, or ease. This is a diagnostic measuring residual bias. The diagnostic is asking the question, is the residual bias observed from negative controls small enough to accept that a calibrated effect estimate can be trusted as unbiased? You pass the ease threshold if the value of ease is less than 0.25. You fail if the value is greater than 0.25. What does that correspond to in the picture? That little picture is our now famous calibration plot. The little blue dots are negative controls, and ease less than 0.25 looks like all the negative controls are producing estimates pretty close to 1. An ease that's greater than 0.25 usually is you see more spread in your negative controls, maybe some signifying potentially positive bias in this particular case. Okay. Stand up if you marked out a database before failing on ease. Wait, no, keep standing, keep standing. It's okay. We only have one. We have 2 failures. Anybody else? 3 failures. You are not a failure. Your study is a failure. I like you very much. Okay? We only had a few failures on ease. Now we can ask kind of like what gives there? So like maybe this wasn't a very good diagnostic. Actually, one of the big insights that we learned about legend type 2 diabetes that is propagated through is that the Odyssey methods are actually pretty good at handling residual bias. The use of large-scale propensity score in the context of a clinical question that is relevant can actually generally be shown to have very little residual bias. Now, why is that? This goes back to the question of quality of study. In this specific case, we chose a situation that's already really close to clinical equipoise. It's a patient who failed metformin, is choosing amongst a second-line therapy. There's a clinical guideline that says when you're a patient that fails second-line therapy, choose one of these 4 classes of drugs. This is clinical equipoise for which you don't have to be a fancy statistician to realize that patients are more or less going to be similar at that exact moment in their clinical progression. So it turns out that while we do employ very advanced methods like large-scale propensity score, and we can prove that it actually works very well, a large part of that isn't so much about that the methods are doing something fancy. It goes back to your first diagnostic, which is lots of the people were really close to clinical equipoise, meaning that patients were really indifferent to treatment choice. Nonetheless, the only way that you can actually evaluate ease is if you are actually systematically evaluating error with negative controls. Something that is kind of important to our community, but it hasn't yet reached widespread adoption until we publish a commentary in JACC. One a month, according to Judy. That's right. Okay, so here's where you should be right now. We have just evaluated 4 diagnostics at the database level. You should have marked in black lines any databases that have failed one or more of those diagnostics, and you have blinded the results by putting your marker all the way through the line. So in this theoretical example here, I had some databases that passed, some that failed. Stand up if you have at least one database remaining with an estimate. Okay, so most people are standing up right now. Hold on a second. What if you failed? Oops, hold on a second. All right, hold on a second. Okay. Oops, I've got the question later. Okay. All right, so right now, most of you have at least one database with evidence in the room. So now we need to think to continue forward. So we're going to keep going here. Now here, I want you to think about the fact that many of you at least had some databases that failed diagnostics. And this is really the importance of diagnostics themselves. If you didn't evaluate the diagnostic, you wouldn't have known that you had a failure, you wouldn't have blinded yourselves, and potentially you would have risked producing evidence that was unreliable. And I want you to think about all those observational studies that you've read, all those observational studies that Harlan was railing on earlier, and how many of them actually had diagnostics that could convince you that what you were looking at was reliable evidence. You know, one of the problems with our evidence generation process is that we don't have a way to prove that our evidence is reliable, but diagnostics are a gigantic leap forward in terms of being able to possibly do that. What I also want to highlight at this moment is that reporting your failed diagnostics is informative to understand if the issue is actually the design or the data or both. So failing a diagnostics is not a failure. Failing a diagnostics is a learning that you can actually action on. And the value of a diverse data network is that it is possible, and as many of you experienced, that some databases will pass and some databases will fail. If you have a single database and you're running from that perspective, you won't take advantage of that diversity. But we got to keep going. We're now moving to section 3 on the plot, the bottom section. These are going to be your meta-analysis diagnostics. This is the section that says, what have we learned from the Odyssey network? We're going to do the same exercise. I'm going to need you to mark out whether or not you can keep hold of your meta-analytic estimate. First diagnostic, same as the last time. In addition to asking the question whether or not you have sufficient statistical power for each database, we actually have to ask the question, do you have sufficient statistical power for your entire network? So what I want you to do is you're looking at your first column of MDRR. If that value is less than 4, you pass. If that value is greater than 4, you should be scratching that database, scratching out the bottom line of your sheet. The second diagnostic is the same one you saw at the database level, residual bias. We're using the ease statistic. But now we're actually evaluating residual bias on the meta-analysis, not just the individual databases. The neat trick here is that as long as we run the same negative controls across our whole network, we can actually double dip in learning about the insights from our negative controls. So what I need you to do right now is if your if your ease statistic has a value less than 0.25, you can hold tight. If your value is greater than 0.25, I need you to take your black marker and mark out that line. Now, the third diagnostic that you're going to see here is about heterogeneity. And this is something that we talked about vaguely, but we haven't actually provided an explicit threshold until now. The idea of heterogeneity, the question that we're asking is, do the databases provide consistent estimates of the magnitude of effect? Here, the statistic that you're actually seeing on your page is the I-square statistic, which is computed through traditional random effects meta-analysis. And the threshold that we're specifying is an I-square less than 0.4. Meaning if you have an I-square less than 0.4, that means that a small amount of the variance in your meta-analysis is explained by database heterogeneity. We would pass. You can see a couple examples of that. That's going to be if you have multiple database lines there that kind of more or less approximately line up, or at least overlap in terms of the confidence intervals. You can see a couple examples there where we fail heterogeneity. And actually, these two examples, I'll highlight. That first one, the failure, it's got an I-squared of 0.85. Look, you've got two databases. One is a statistically significant increased risk. The other database is a statistically significant decreased risk. I didn't make up these plots. These are plots from our Legend Type 2 Diabetes study. We have a target comparator outcome, maybe someone in this room, who is looking at a result where one database said, we've got an increased risk, and another database said, we've got a decreased risk. That's a nice example of heterogeneity, because now you've got to ask the question, how do we know which one is right? Because they both probably can't be. The other example of this is a little bit more subtle, but you can see you could also get this idea that some databases kind of nudge one direction, some nudge another direction. But in all of these cases, it's raising a new open question that you can only get by having a diverse data network together, which is asking the question, is the answer that we're getting truly consistent? Okay? So if you had I-square greater than 0.4, you should be scratching out this entire line. Want to ask you now, stand up if you failed your meta-analysis diagnostics, meaning you've got a black line down the last page, like this example on the right. Stand up. Okay, keep standing for a second. Okay, so hold on. Okay, so it's probably only about less than 10% of you here have failed meta-analysis diagnostics. Now, stay standing for a second. If you are standing because you failed meta-analysis diagnostics, raise your left hand if you had more than 2 database estimates up top that passed diagnostics. Okay. So it looks like, okay. And some of you, okay. Yeah, that was a bad question. How many of you had 3 databases? 4 databases, 5 databases, 6 databases, 7 databases, 8 databases. Okay, 9 databases. There's only 9 on the sheet, so I'm not going to ask Roger if you have 10 databases. You're just stretching your arm. Okay. So I want you to think, thank you, you guys can sit down. So I want you to think about what that means. We've got about 10% of the room that had multiple databases producing what could be independently reliable evidence, but it's only by looking at a network study that we can actually see that there now has a question about the reliability because the estimates aren't necessarily consistent. Okay, so now you all have pieces of paper, some of them marked up a lot, some of them marked up a little bit. So let's go back to talk about how we interpret this. So before we talk about what did you learn about your effect estimate, let's just start by understanding our strength of evidence. So so I'm going to go in order here. How many databases do you have that pass diagnostics? Stand up one more time. If you have no databases that pass diagnostics, please stand up. I know we've got one in the back. She's not standing. She feels called out. Does anybody? We got two? We got two that failed. You're not a failure. Your study is, though. Okay? Oh, three. Okay. Okay. So think about this from the perspective that there are 500-ish studies in this room. Less than 5 of you have no evidence to share. Now, I will assert that's actually a meaningful, powerful fact. We should think about what are those 5 studies and why didn't we actually learn something? That's actually informative. Now I want you to stand if you had at least one database that passed diagnostics. I'm not particularly good at math, but that should be all but 5 of you. All right. Okay? And then I'll ask you to sit if you only had one. Okay. Sit if you only had one. So it looked like about 15% of you sat. So think about that. We ran a network study with 9 databases. You only had 1 that passed diagnostics. So we think about the strength of evidence. That means you had other databases that either failed diagnostics or didn't have sufficient information. So you're sitting down because I would say the strength of your evidence that you have, we should probably think is a little bit weaker than those that are standing around you with multiple databases. I want you to sit if you only had 2 databases. Okay? Sit if you had only 3. I'm going to catch myself because I just said only 3. When was the last time you read a study that actually had 3 databases? That wasn't an Odyssey study. Okay? Sit down if you had only 4. Okay, so now more than half the room is sat down. We started with a network of 9 databases. Now we're down to less than half of you. Sit down if you had only 5. We're now down to about 10%. Sit down if you only had 6. Okay. Sit down if you had 7. Sit down if you had 8. Roger just loves stretching his legs. Okay, so I want you to think about this. We had 500 studies in the room running analysis across 9 databases for an extremely prevalent disease, second-line treatment using drugs that are very commonly used, and yet almost all of you were sitting down, meaning that not every database could provide sufficient evidence. That's really important to know, and that's the demonstration of why we need our entire diverse network, because it's not going to be possible to generate evidence on every database all the time. But I also want you to be encouraged by how many of you were standing with 3 or more, 4 or more, 5 or more, because that starts to become stronger evidence. Now, I want you to stand if you have results from at least 1 claims database and at least 1 EHR database. Now, I recognize that I didn't provide the full context, but I'll just quickly highlight for you. There's a database called Optum EHR. That's an EHR database. The VA is an EHR database. And then you've got the claims, Meritive, Open, Optum Informatics are claims. So stand if you have at least 1 claims and at least 1 EHR. Okay, I'd say that's about a 50-50 split. So think about that in terms of strength of evidence and diversity of data capture processes. If you see 1 artifact in a claims database, you're like, I'm not sure that that's true. You start to see the similar consistent effect in multiple different types of data, you might have learned something. Okay, you guys can sit down. And now I want you to stand if you had results from at least 1 database in the US and at least 1 database in Europe. I'll highlight for those that don't know the databases, the one that's called Germany and the one that's called France. For you US-centric people, those are European. All the rest of the databases are in the US. Is anybody standing up that has at least 1 in the US and at least 1 in Europe? Okay, we've got, okay, stay standing for a second. I just want to get a sense. That looks only like 5%. So we want to have strength of evidence be based on having geographic dispersion, and we can see that right now only about 5% of you even have 2 continents represented. You'll also notice I didn't even ask about the Asia-Pacific region because we had no Asia-Pacific databases on this form. So if we think about the continuum of what strength of evidence needs to be, strong evidence would be evidence that we can see across North America and Europe and in the Asia-Pacific region, as well as in South America and Africa, and all of our partners that we have on our broader Odyssey map. Less strong evidence is represented by having data that's just in US data. Less strong evidence is based on just having a claims analysis. The reason we need to be collaborating together is if we're talking about strength of evidence, we need to talk about all of these attributes fitting together. And if you are doing a study where you can say, I've got more than 4 databases, and I have more than 2 data capture processes, and I have more than multiple countries and continents represented, it's really hard to think about how you could come up with that unique bias that is going to torpedo your study after applying all of our analytics. Okay, so now we've talked about the quality of the study, the strength of the evidence, and now we're going to actually talk about the effect estimate. For those of you who didn't cross out your meta-analysis, this is the thing at the very bottom right. The first attribute I told you is certainty of the estimate. Before we talk about what the actual answer is, we want to ask the question, how certain are you about the answer you're about to provide? So here's a rule of thumb. Take the upper bound of the confidence interval, divide it by the lower bound of the confidence interval. That value, if that value is less than 1.5, then you're pretty certain. And if that value is greater than 3, you're pretty uncertain. Okay? I see some people pulling out phones to do the math. It's just 2 numbers. It's okay. Okay? You got an upper bound and a lower bound. You're seeing on the sheet, you got a point estimate, a lower bound and upper bound. Divide the upper bound by the lower bound and get a sense of if you're pretty certain or pretty uncertain, knowing that this is extremely unscientific. Stand up if you're pretty certain. Okay, it's about 30% of the room. So I want you to think about that for a second. We did the world's largest study in diabetes with these 9 databases representing hundreds of millions of lives and millions of patients with diabetes. And yet, in this room, only a third of you ultimately end up with a result that is highly certain. Okay? The reality of us doing observational research in this space is that even when we have all of the chips going in the right direction and working with us, that we still may be uncertain. And it's okay to say, I don't know. We should actually want to communicate that our current state of knowledge is I don't know, because that is at least honest, instead of cherry picking the answers we think or trying to be more confident than we are. Okay, you guys can sit down. The third that are fairly certain. I wanted to give you a rule of thumb, but for those that were doing the math and it was too hard, I'll also give you a rule of pinky. If your confidence interval is wider than your pinky finger, then you're probably uncertain. Now, I'll admit that this requires some calibration, but it's a good rule of pinky given that we have a rule of thumb. Okay. Everyone's like, what? What? Okay. All right. All estimates are equally good. There's nothing magic about p less than 0.05. If you have blasphemy, if you have a quality study and you have strong evidence and you have certainty, then you've produced reliable evidence. And the answer you're holding is information that the world deserves to know. It does not matter what that answer is. Now, if you have bad quality studies, you should be skeptical. If you don't have strong evidence, you should be skeptical. If you are uncertain, you should be skeptical. But the estimate that we're going to look at, that's not the thing that should determine whether or not you're moving forward. What should determine whether you're moving forward with evidence is whether you have a quality study with strong evidence, with certainty. That's something that's actionable that we should be moving forward. And as the limitations to our study, it has nothing to do with what your p-value is. It has everything to do with asking questions about what is the quality of the study, what is the strength of the evidence, and what is the certainty that I'm representing. Okay? So you could be holding reliable evidence if you have an effect estimate like this. This is the one that probably many of you are like, jackpot, because we've got a point estimate that is an increased risk with a confidence interval and a lower bound greater than 1. And many of you are like, yeah, he didn't give me a p-value, but I know that a lower bound greater than 1 is p less than 0.05. Stand up if you are holding an estimate of reliable evidence that looks like this. Oh, I'm sorry. If you have an estimate that looks like this picture, which is a confidence interval where the lower bound is greater than 1, I want you to stand up. No. I'm asking a precise question here. So I'm asking you if you're holding reliable evidence, meaning that you had certainty, that you have a picture that kind of looks like this. Okay? So look around the room. We only have, this is less than 5%. Have a picture like this where we're seeing an increased risk, presumably with some sort of, we believe that it could be reliable evidence. But the rest of you aren't out of luck, because what I just said is that all estimates are equally good. It doesn't matter whether you have an increased risk of p less than 0.5. So now I want you to stand up if you got a picture like this. Now, interesting picture. The upper bound of the confidence interval is less than 1. Which means that what we have found is a statistically significant decreased risk. So stand up if you're holding reliable evidence that looks like that. Okay. We have a few more decreased risk than we did increased risk, but I'd say we're still at like less than 5% of the room. Okay. Now, these two examples, these are the ones that if we were promoting publication bias, you all would be running to Jack or some other journal and saying, here we go, we got an answer, and we got a p less than 0.05, huzzah, we've got our paper to go with. You guys can sit down now. You could also be holding reliable evidence if it looks like this. I want you to stand up if you have something that looks like this, where you believe that you have a quality study with some belief that you have strong evidence, with some certainty, and yet your confidence interval contains 1. I want you to look around the room. There's like 60% of you that are currently standing. Think about these 60%, maybe more, maybe even 70%, okay? Think about the last time you saw a paper that published something that looked like this. Probably very, very few, because these aren't nearly as sexy to people as the first two examples. Yet, think about what you guys can sit, that's okay. Think about what you just learned. You just said that you ran a high quality study, that you were able to show that you had strength of evidence, that you were certain in your answer, and that it turns out that the answer is that the effect estimate is small, and that you see no evidence, no substantial evidence of a difference. And that if there is a difference, the difference is bounded by this tight confidence interval. That's important information. If I'm a patient choosing between your target and your comparator, and I'm asking the question, should I be worried about a difference between those? It's just as important for the answer to be no as it is for the answer to be yes. Which means we can't just cherry pick the ones that are p less than 0.05 and run to the journals. We need to figure out how to get all of this evidence out in the hands of those that need it. So ask not what your p-value can do for you. Instead, ask yourself, what is the quality of the study? What is the strength of the evidence? And what is the certainty of the estimate? And if you can answer those questions, then you may be holding reliable evidence, and you should be thinking about how to use that reliable evidence in the context of disseminating to the people who need it. I'm going to skip that. Actually, no, I'm going to go back to that for just a second. No. Yeah. All right. So I'm going to try to restate George's observation here. So a poorly calibrated estimate that was somewhere order of magnitude of about 10% of you stood up when we added up those that reported to have a statistically significant effect, either positive or negative. And you have to remember that those are statistical probabilities, which means if we are running well-calibrated statistics, we would expect 5% of you to be standing up by chance alone. So even those 10% of you, probably about half of you, got lucky or unlucky as the case may be. And that probably means that some of the evidence in this room is real and would withstand the uncertainty of statistical probability, and yet some of the evidence we had, while it meets our statistical threshold, is firmly within the space of what we would imagine. I'll also just hearken back to the work that Martijn and others have led when we looked at the magnitude of publication bias, where we generally see that if you scrape everything from PubMed, 80% of things are statistically significant. Whereas if we think here, we got a room and we're well calibrated, some of these drug outcome pairs should be real. If about 10% we're seeing and 5% are due to random chance, that means that there's some small amount of differences between these treatments that we're observing. Okay, so all estimates are equally good and there's nothing magic about p less than 0.05. The other thing you have on your page is the top section, which says how often. And I'm going to assert that if you're going to disseminate reliable evidence, you need to be able to provide not just the estimation result in the hazard ratio, but you also need to be able to provide the characterization, which is why it's important that we are reporting incidence rates to be able to understand the absolute risk that includes both background and attributable risk, as well as that causal estimate. And we need to be able to translate the estimate into its uncertainty. Now, some of you failed your meta-analysis diagnostic. And this is an interesting scenario, right? Because you had database estimates, but I made you scrape out the final answer, which is the thing you were supposed to be looking at. So one thing that I want you to think about is like, why can that happen? That could be because there's true population differences, or it could be because there's differential bias. An action that I could propose to you right now in absence of a rule is just report those estimates and learn why the estimates are heterogeneous. And I'd actually argue for those that are thinking about meta-research and methodologic opportunities in our community, this is a scenario that's not only a demonstration of why we need our diverse data network, but also why we can conduct more methodologic research to really get to the bottom of heterogeneity. And as some in the community have said, heterogeneity is not your foe, it can be your friend, because you can learn quite a lot by observing it. And what if you failed all your database diagnostics? We only had like 5 of you. I would assert that you weren't a failure. Because it's actually really, really important to know that if we did this large-scale study, that you can't answer, you're not capable of answering the question. And one of the things that's my pet peeve when I read observational studies is when it just says at the very end, more studies are needed. Because if right now, at this moment in time, we've run the world's largest study, the answer to the question of why didn't we get a statistically significant effect isn't because we need yet another person to do a one-off analysis of a one-off database. We actually need to sometimes actually come out with the communication that says, at the current time, with the current data and their current methods, the answer is, I don't know. That needs to be accepted as information, just in the same way that we can actually report when we do have evidence. And given that Legend is currently the largest network study that's ever been undertaken on this, and you all stood up and you saw that many of the questions still can't be answered, we need to be pragmatic to talk to clinicians and patients and policymakers about the fact that many TCOs that are out there, despite us having the world's largest data network, are still not going to be answerable. And that's really important to be able to know what questions can be answered and which ones can't, and for us to be honest with the state of that. So the scale of Legend type 2 diabetes, we had 14,784 studies. You all just broke unofficially the world record for most studies interpreted in an hour. We just did 450 of them. So for every target comparator outcome, there's a valid question that deserves evidence for. It's now our responsibility to communicate that reliable evidence we have for those who can benefit from it, but also for us to communicate when we can't produce reliable evidence. And as Harlan nicely highlighted, one of the things that makes this community special is that we are trying to get to the truth of these answers, and the truth may be that we've learned something, the truth may be that we can't learn something, but in all of those cases, as long as we have a framework for reliable evidence, we can actually help healthcare in general. So what's your immediate next steps? Most of you, at the end, have in your hand a piece of reliable evidence that could be published and make a difference in the lives of patients. Most of you have something actionable right now. You're holding it. All of you have permission to disseminate that evidence. And you have the explicit encouragement of the Legend leadership and the broader Odyssey community to do exactly that. We just ask that if you're going to take this call to action, just coordinate with us, work with the Legend team, stick to our Odyssey authorship guidelines, but we want you to help us with disseminating this evidence because we cannot do this alone. You saw an entire stage showing 6 studies. You're holding 450 studies. There are 14,000 to go. We need to work together if we're going to scale the evidence generation process. But you also don't have to say, geez, I've got a nice, reliable piece of evidence, but I can't do it alone. It's too hard. Earlier today, oh, they're down there. Earlier today, you made some friends. You made a dream team. You now have an opportunity to connect with your dream team. Think about what information you're now holding. Think about how you can collaborate together to get this evidence out into the hands of those that need it. You heard a call to action from the JAC leadership that there's a place for our community to be thinking about getting the evidence out there. You heard a call to action about our data network wanting to do impart further generate more evidence. Now you're hearing a call in action from me and the leadership that it's not good enough for us to just standardize the research question. It's not good enough for us to just standardize the evidence generation process. It's not even good enough for us to standardize objective diagnostics. What we need to do is standardize our interpretation of results and collectively work to get this evidence disseminated at scale for everybody's benefit. And so that's my call to action for you now. Okay. But first, you have a second call to action, which I need you all to go out into that atrium because we're going to take a group photo. And after the group photo, hopefully you can go maybe stand with your dream team or whatever. Craig and the team is ready to take a group photo. After that, you're going to come back in this room and we're going to have a hell of a lot of fun in this ballroom for game night. We're going to transform this room into something special for our community that I'm sure you'll have not experienced before. But I want you to be reflecting on what we've talked about in terms of the content. We've worked hard, and now we'll start playing hard. But right now, please go out in the atrium and get set up for our group photo.